Good afternoon. My name is Melanie Usher, and I'm with the Arizona Telemedicine Program, Southwest Telehealth Resource Center, and welcome to today's webinar series. Of course, we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples, and today Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So again, welcome to today's program. A couple of tips: when you joined, your phone or your computer microphone were muted. We do use the chat function for any questions, Q&A. We also have a post-webinar evaluation where you can also get your CMEs. I will be sending out an email to everybody that joined us as a reminder. And for all of our EMS folks, you can respond to that email and I will get certificates sent out to you directly. This is being recorded and it'll be on our website at a later point in time. Again, that URL will be in my thank you email to everyone. This was sent out in some welcome emails, and it was also on the registration. I'm not going to read through it, but these are the continuing medical education informations, objectives, accreditation, and disclosure. Of course, our standard disclaimer. I think everyone can read that. I don't need to read it out loud. And be sure to look to our website for upcoming events. We do have another one in this series coming up in September. I'm going to have to double check the date, but it's going to be on scorpions, so that's going to be exciting. And again, here's the evaluation link. I will put it in the chat in just a couple of minutes when I'm done with this. And I'm going to, of course, I love introducing this group. This is Dr. Klotz and Dr. York, and they are with the Envenomations, Intoxications, and Travel-Related Diseases, more common than you think, and what to do. Today's topic is going to be on the kissing bug. So we've got just a couple of slides here that I'm going to let Dr. Klotz talk about this series. Dr. Klotz?
Yes, thanks for joining us on this series. We've got still quite a number to go through and a lot of venom and excitement ahead. So we've already had, I think, maybe 10 talks, and they're all archived. That's the good point. And some of them are just pretty gripping, I think. And hopefully today's discussion will be too. So we're talking about human diseases that are due to just what Melanie has outlined, envenomations and intoxications and so forth. That's kind of what we're stressing, but a lot of these don't have death as a final arbiter of this whole process, which is good. And there are many treatments that you can employ in the field or at the hospital for these incidents that we're talking about. So Melanie, I'm going to go ahead and let's see, share. And then, okay.
You're good to go.
There we go. All right, so hopefully this ancient computer I'm using will work. But thanks a lot for attending this afternoon conference. We're going to talk about kissing bugs, allergic reactions, and Chagas disease. So there are 3 points here. But today, I want to just concentrate on kissing bugs. All of these are related, but as you'll see, you've got to understand kissing bugs first, or everything else is not going to follow properly. And so in about 25 minutes or so, I'm going to tell you what I think you need to know about kissing bugs that is absolutely accurate, and no suppositions here. And I have been studying them for almost 20 years, and I'm very fond of them, even though they can cause a lethal disease, although they do not, basically, in the state of Arizona. So let's get started here. Well, why will it not go? Okay, so What's the diagnosis? Let's start this off with something medically related. A 68-year-old man from Sahuarita awakened suddenly at 2 a.m. in the morning with shortness of breath, diffuse urticaria, itching all over in August of 2014. He vomited, felt palpitations, and then fainted getting out of bed. He was brought to the emergency room with hypotension and tachycardia. He had taken amoxicillin the previous morning for a UTI, ate strawberries at lunch, shrimp at dinner, and had peanuts with a cocktail the evening before. However, his wife held up a little envelope, and inside of it was an insect. So, what is your diagnosis? Hopefully, the answer is anaphylaxis, which Dr. York will address on a follow-on talk. And it was caused by the saliva that was introduced while feeding by this kissing bug. They are blood-sucking bugs. A follow-on talk by Larry will, of course, talk mainly about anaphylaxis. But here we're going to concentrate on the kissing bugs because there's so much misinformation and a lot of fear generated amongst the public by this misinformation regarding kissing bugs. There are actually a large group of true bugs, in other words, Hemiptera, and they're in a superfamily called Reduviidae. So you're going to see this term in the literature if you look under these bugs on the internet. They have a strictly hematophagous lifestyle. They survive by feeding on blood. They have to take blood about every 2 weeks in the mating season and their active season in order to survive. And to do so, they have adapted to living in the nests of a lot of vertebrate animals like opossums. And in Arizona, they live in the nests of pack rats. They are unspecialized feeders. Unlike bed bugs, which are also true bugs, they only feed on humans, or bat bugs, they only feed on bats. But kissing bugs will feed on virtually everything that is either a vertebrate or even some insects and birds. Now, the next two slides are of bugs that are not kissing bugs, but they're often confused with them. And so I get many photographs of wheel bugs here you see on the left, which has the generalized shape of a kissing bug, except for this structure, we could call it a wheel, from the head to the thorax or over the abdomen. But their head, which is on this elongated tube, and you can see the eyes, also they have a proboscis that they can extend and feed. These are insectivorous insects. They have a vicious bite. You don't want to be bitten by them. And here are two lookalikes commonly seen in areas where kissing bugs are. On the left, upper left, is a seed bug. Now, the ones that you see in Tucson substitute the gold orange for a little bit of red. And you'll have an accurate description of the black seed bug of Arizona, which is the most common confusing insect that I've encountered for people. And below is a Midwestern variety called a box elder beetle. It does have some of the colorations very similar to our most common kissing bug in Tucson and Arizona. On the upper right is a leaf-footed bug. They are herbivorous. They don't bite humans. And below is an assassin bug, which is also an insectivorous bug, which can deliver a real bite. And these biting bugs like the wheel bug and the ambush bug, actually they capture another insect, bite them, inject proteases, and then just wait while the insect dissolves right in front of them and they can suck the innards out. But kissing bugs, there are about 150 species, and the most common genus is known as Triatoma. So you're going to see that term on the internet and so forth very commonly. It's very common in Arizona. We have up to 7 species in the state. There are 11 total in the United States. Although all these species may look a little different from one another, they all behave the same. They're obligate blood suckers, in other words, indulge in hematophagy, and all may harbor the blood parasite Trypanosoma cruzi within their rectum that can be passed in the feces. And this is why this is an important medical topic, because of this blood parasite. And we will talk about it in a separate conference in the future. So why are kissing bugs an important topic? Well, because they harbor Trypanosoma cruzi, the cause of Chagas disease. Carlos Chagas was the discoverer of the parasite, the vector, kissing bugs, and the disease that occurred in humans. Kissing bug bites are very frequently associated with pretty severe allergic reactions. And 2 people have died of anaphylaxis from kissing bug bites, one in Phoenix and one in California that I know of. AIDS patients who have immune suppression anyway, their CD4 counts are below 200 and they're not really equipped to fight off something like T. cruzi, Trypanosoma cruzi, if bitten or swallowed. And it causes a severe cerebritis, which is untreatable basically. Transplant patients can have a disease that looks like rejection if they are infected with T. cruzi. And it's estimated that as many as 300,000 immigrants from Latin America, let's say that, are infected with Trypanosoma cruzi and living in the US. There are an estimated 3 million people with Chagas disease, this blood-borne parasite, in Mexico. And we have had at least 8 autochthonous cases in the US. That's a mouthful. But basically what it means is that someone in the United States, Arizona, for example, or Louisiana, has been shown to have active Chagas disease. So they were all documented by actually finding blood smears by these people that had the parasite in the blood. They had the kissing bugs in the home or adjacent to it. And there are perhaps 100 cases inferred from positive serologies of people who have never been to Latin America or endemic areas where, like Mexico or Brazil, where the disease is rampant. And so these are referred to as autochthonous, very fancy word, meaning that's been incurred here in the States. So here's the Triatoma life cycle. Remember, that's the most common genus, and we have 3 in Arizona, in Tucson, which are easily found almost all the time during the summer months. They start with eggs. You can see the embryo developing in these little pink eggs. In the middle is an eclosed egg where the operculum has fallen off and the nymph has crawled out of the egg case, and you see one here on the right. This is probably a 3rd stage nymph. They have 5 stages of nymphs, and then adult, which you see in the right bottom corner. And the difference is that nymphs at no time have wings. You can see these waxy sort of wings on top of an adult Triatoma rubida on the right-hand bottom corner. And each stage as they pass through, they have to have a blood meal, and then they undergo loss of their exoskeleton. So here's the main triatome in Tucson. It's Triatoma rubida. These are adults. And I venture people who live in Tucson who are watching this have all seen these at one time or another. Here's another one, but not seen as often. It's called Triatoma protracta. It's actually quite beautiful. It's this very shiny black surface, and you can see the wings covering the abdomen here. Now, here is the picture that's the meat of the problem with these darn bugs. On the left, you can see this thin, spindly-legged insect crawling along the surface of a board here. Their antennae are weak, their legs are long and skinny, but you can see at the head, the eyes are on this long cone nose. The antennae project from the cone too. And then they have a proboscis that they fold underneath. And that's where it resides when they're not feeding. But when they want to feed, they extend this proboscis because they can detect 1 to 2 parts per million of CO2 or lactic acid. They have thermal receptors. They can tell where the blood is coursing through capillaries below the skin. And then they have 2 little stylets that they protrude out that cone nose and cut through the skin and start the bleeding. And at the same time, their saliva contains anti-clotting agents and painkillers, so to speak. The bite itself is painless. But because of the reactions to it, and the swelling and the erythema that goes on, sometimes for several weeks after a bite, people often relate that it's a painful bite, but it's not. Just think about it. Any self-respecting blood-sucking animal isn't going to cause you to have pain when they're taking the blood because you'll clobber them. But that's not the case, actually. And you can see on the right a 5th instar of one of these bugs that's just plump, and the wings are developing under the membranous structure that's over it, because the next stage will be an adult with wings. So what about Chagas, really? I mean, I've got to mention something about it since I brought it up, but it's a parasitic disease, and it's carried by these bugs, and as I said, in the rectum. And it also causes an enzootic amongst a lot of animals. Kissing bugs are found in the lower 24 states of the US. They don't extend very high because they need warm climates. As I said, the parasite, after feeding on an infected mammal like a raccoon or a pack rat here in Tucson, stores the parasite in the rectum, where it develops into another stage of the parasite called epimastigote, which can then invade any mammal, including a human. Other ways of acquiring this, other than, at the time of rubbing feces or something into your wound or into your mucous membranes, is the disease can be passed congenitally from mother to infant by blood transfusion, by organ donation, and all of these have occurred. And the most common thing that's going on presently in the Amazonia region is contamination of food and drink. These communities of native peoples gather together, they have a big party, they harvest acai fruit from these palm trees, where one kissing bug species loves to live, defecating on the fruit and so forth. All this fruit is then mashed and put into a drink. If it's not pasteurized, you'll have hundreds of people infected with Chagas disease, sort of an epidemic all at once. And this is the way most of the disease is being diagnosed at the present time, and likely may be what happens when people from the United States become infected. Now, the vertebrates like raccoons, and think of your dog or cat, they eat these bugs. This is how they get infected. Dogs get Chagas disease, and they may have severe disease and even die from it. Okay, so where do you find Chagas? Look to South America and Central America. Um, and the hot spots are basically the Chaco region of Argentina, the Amazonia region of Brazil, Bolivia, and Peru. And these all represent, 1% of the population or more, the general population with infection with Chagas disease. Okay, and how is it taught that the disease occurs? Well, I don't think this is what it applies to the United States. So I think what we will find is that the problem in the United States is different than what it is in Latin America. But what is taught in Latin America, and is probably at one time current for Latin America, was that humans become infected when the bug defecates during its blood meal on the person, and then fecal material containing the parasite is inoculated through the bite wound or intact mucous membranes. Mathematically, the likelihood of this is very low indeed, 1 out of like 2,000 or 3,000 bites. But what is the evidence? Not a whole lot, and certainly doesn't exist for people who have acquired autochthonous Chagas here in the United States. Does it matter? Yes, it does, because being bitten doesn't necessarily equate to being infected. Although to hear all the stories about kissing bugs, people, particularly in the Southwest, think, oh, gee, I've got to be tested for Chagas right now. Anyway, the local issues in Arizona and the southwestern states mainly revolve around the pack rat. And here we're talking about the foothills of the mountains around Tucson, Phoenix, and San Diego. This is where everyone's moved their communities. They move right out into the desert, they build a nice home, and there's no keeping these bugs out of any kind of home. You'd have to be spraying insecticide 24/7 to keep them out of your home if you live in the desert areas. At any rate, I'm aware of one study performed by someone from the University of Arizona who looked at 500 pack rats, took blood samples, and 50% of the pack rats had evidence of Trypanosoma cruzi, this blood parasite, on their blood smears. I mean, it's just, they are definitely our reservoir for the Southwest. And the kissing bugs live in the nests of these animals, and then they move at particular times of the year. And that is May and June. In May and June, as the floor of the desert's heating up, there's no rain, little wind. About an hour after sunset until 10 p.m., you'll see adult kissing bugs flying. Now, this is the best way to capture them, if that's what you'd like to do, is to put out a black light at that time. As long as there's no wind and it's warm and no rain, doesn't rain for a few days, they will fly and you will collect them. And sometimes in great numbers, because some nights are better than others. But they're very poor flyers. They come in, they sort of crash right in front of you, and you go, oh, there's one. And you capture them in that fashion. So traditional wisdom has said that pack rats are the problem in Tucson. They are a problem. I'm not going to say they aren't. But actually, in our studies, we discovered they're more Catholic in their taste. They'll feed on rodents, javelinas, mammals, birds in general, snakes, likely lizards, toads, and they can even survive through life stages as nymphs and lay eggs as in adults by feeding solely on cockroaches. So our former colleague, Justin Schmidt, believed that was how they survived in the desert in a bad year. Just find a home with a lot of cockroaches. And basically, cockroaches are as big a problem as kissing bugs are for homes in Tucson. So what are the remaining problems? The kissing bugs or triatomes have become an emerging medical issue in the United States because of the movement of humans into their habitat, not the reverse. We're building our homes right in their desert habitat amongst the cholla and prickly pear cactus, which is where the pack rat makes its home. And it is the favored host in this area for kissing bugs. And they don't leave these nests until the host dies or something happens, a rattlesnake eats the host. Then the kissing bugs will, the following year, they'll take off. So all the females and males that have wings, these nymphs don't have wings, the adults will fly, and they are in a starved condition, so they fly better, that's for sure. They're real thin. And unfortunately, a lot of the females are already pregnant, so to speak. And they lay eggs within about 2 weeks, up to about 15. They'll do that 5 or 6 times. So if they get in your home, you may have a problem that's ongoing for some time because of the nymphs that then go through their stages of feeding every 2 weeks on you and your pets. And the rate of carriage of Trypanosoma cruzi by these bugs is greater than what we found in historical records, but we're doing it differently. We're using PCR, it's very sensitive, as opposed to what I was telling you about just looking at blood smears or smears of bugs rectum that's been smashed on a slide and then looking for it. Well, we found that the local species of kissing bugs do not defecate on the host, so not really part of that routine, as I explained to you earlier, that they teach in Latin America. Anaphylaxis and other allergic reactions are really common in Arizona. And one community in Southeast Arizona may have a year-round colonization of the houses by kissing bugs, which live out their life in these homes. So let's just spend just a moment on the homes. What kind of housing predisposes kissing bug living within? Well, in Mexico, it's on plastered walls and wood walls, and they can reach high densities within these homes, often 10,000 bugs in one place. In Costa Rica, dirt floors and firewood in the house are all associated with kissing bugs. In northeastern Brazil, it's the surrounding area around the house where they have goats and donkeys and what all, guinea pigs in the hall and so forth. All this biomass is attracting these insects. Here is a picture of Bisbee, Arizona, which we studied. We studied the homes, trying to figure out how do they get in there? What is the problem? Before I started this study, I thought, well, it had to do with, well, they have an old home stock there in Bisbee. No, it doesn't matter how old your home is. If it's 2 weeks or 100 years, a kissing bug can get in it. They can slither right under a threshold. And so, however, what we found is also that in those people in Bisbee who complained of having kissing bugs in their home feeding on them, 90% of these people had pets sleeping in their bedroom. Not a good idea, really. They're just offering more biomass. So what can they do? Reduce clutter inside the houses, eliminate junk. You cannot imagine what we saw we looked at all these homes, because I made notes on them, and wood piles, trash, other objects in the peri-domestic environments need to be removed. Manage the surrounding vegetation and conserve the local fauna. I mean, don't shoot off your deer or something like that. It would make nice meals, a blood meal for the kissing bug. Replace all white lights on the outside with yellow lights because they're less attractive. Seal all structural cracks and crevices. And one thing that's a fad now is everyone wants a chicken coop. And where do they put it? They put it right next to their house, probably next to the window of their children. And it turns out kissing bugs love chickens. It's their favorite host. Take a blood meal from. It's real simple. It's not dangerous. Go out there at night. They're all on a roost. Crawl through a few feathers and have a nice meal and then go home in the morning. Well, and they will feed on chickens as opposed to any other sort of host that you could offer them. So we found a lot of this, and mothers showing me pictures of kissing bugs crawling down towards their children on the wall next to the crib, and outside is the chicken coop. So you can't keep them out, but you need to make a try. So kissing bugs in the Southwest are bloodsuckers on a wide variety of vertebrates. Again, the term is hematophagy. They are probably diurnal feeders in nature on pack rats or other nesting animals that are only out nocturnally. But in our homes, they're nocturnal feeders. So they're going to bite the human in the middle of the night, usually. And that is one of the clues to what your anaphylaxis may be due to in the ER is, when a person's pulled in at 3 in the morning, 2 in the morning, it's probably not the antibiotic from the day before, the strawberries 12 hours before that, which people in the emergency room reach for food allergies right away. But here it's simple. Hey, it's 3 in the morning. And sometimes they'll bring in a kissing bug with them. So just some thoughts. There's really no solid evidence of bite and then feces being rubbed into the wound associated with human infection in the United States. Likely, most cases in Latin America and even the US are due to oral ingestion in some manner, with having the food or the water contaminated with feces, or perhaps even swallowing the bug. I had pictures from a daughter of her mother in the nursing home, and there was a big triatoma recurva crawling on the tonsils of her mom, who, was in the nursing home for post-stroke. There are 2 people like this, and so they can get inside the orifices of humans as well and be swallowed and cause disease. However, the public's going to continue to associate biting with disease, so this is something you want to stress. Now don't get all stressed out about this. And excuse me. And public health focus should be upon being accurate in what they're saying. Many of the calls, I get them every week, and photos sent to me, are not kissing bugs. So you want to make sure, if you can, are they kissing bugs? Is the whole story consistent with kissing bugs? Is the feeding at night? Or if they're feeding during the daytime, it's not likely. Although I've had people actually uh, being fed upon during the daytime. Uh, so you got to clean up the house. You want to keep them out. You don't want them occupying your house 12 months of the year. So we should stress good home hygiene and when necessary, use pest control for goodness sakes. I mean, that was probably the hardest thing to convince people of in Bisbee was just get a pest control agent out here, eliminate your 50 bugs that are in your house. So I'll leave it at that. And Larry's going to follow on with a discussion of anaphylaxis and how to treat it. And I hope I've left him enough time. Have I, Larry?
A perfect amount of time, and there is a shocking amount of crossover. We have slowly become one person the longer that we've done these things, I think. You'll see. You'll see.
All right.
All right. Let's switch over here real quick. Okay.
We do have a question in the chat.
Oh, let's see what we got. All right, I think we got one for you,
Yeah.
Dr. Kloss. All right, so we have a physician writing in. So they were kissed by a kissing bug a couple of years ago. They saw the engorged bug on the wall in the morning, had a PCR done, which was negative. Was that overkill, or what would your recommendation be?
Well, usually no one is that quick to identify the bug and then check the bug to see if they are harboring uh, Trypanosoma cruzi. So kudos to you or the individual involved here. That's pretty clever, but that isn't available to everybody. And if you did that for every bite, it'd be an expensive proposition. So I don't recommend that. The reason why is people, like, for example, in Bisbee, when we studied community, we studied over 100 people from Bisbee. In the aggregate, they were bitten thousands of times. So you can imagine. And not one individual in that group had Chagas disease. We tested everybody for bloods for Chagas. And that's pretty much every examination we did of communities that there's no one has it, basically. I'm aware of only 2 people in Tucson who have resided solely in Tucson who have positive serology. So we don't know when it occurred, but they're also teenagers and they spent a week or 2 before they found out that this was positive in uh, in Mexico. So I don't know the meaning of all of this, but this is one out of thousands and thousands.
And I think that's a good segue, is
Okay.
for my portion, talking about kissing bug bites, I admit I was in the exact same frame of mind. My training was infectious disease. When you think kissing bugs, you think Chagas. That's the big, terrible thing that can come from it. And just as a teaser for when we get to it, it can be a terrible disease. The treatments are not a whole lot better depending on some of the circumstances there. But the reality is, Chagas disease, as it relates to these bites, is probably the most insignificant concern as it relates to the things that can much more frequently happen. So, using a case that you all might find very familiar, this is an individual in their 60s, about 2014, 10 years ago, that suddenly woke up in the morning. And key points there, and this was brought up again, this is, I am assuming, the exact same individual from Dr. Klotz's portion, but it is a great case in the symptoms in the presentation. So the first thing to be aware of is this individual wakes up unexpectedly very early in the morning, so presumably unprovoked. The symptoms that they experience upon wakening, nausea and vomiting, they're diaphoretic, palpitations. And when they look at their left elbow, Wouldn't you know it, there's redness and swelling already there. Now, as this individual gets up, they have a syncopal episode witnessed by their wife, who's right there. They are brought to the emergency room and intubated. So let's let that set the stage because, again, Chagas disease is what I think everyone worries about with kissing bugs, but the reality is that is extremely rare in this country for that actually be transmitted, especially in this manner, presumably from a direct bite from the insect in question. And as Dr. Klotz mentioned, what's shocking is how many of these things do in fact have Trypanosoma cruzi if you are to actually go do the PCR and check them, but yet it's not being transmitted as a part of these exposures. What we're really worrying more about is that a much larger number of these folks may experience localized reactions, and in some cases, as far as anaphylaxis. Now, it's a huge spectrum, as all of these things are. Many folks may have absolutely no idea that they've even been bitten in a lot of these instances. Now, the other thing here to further explain the third bullet point, it's possible that you could get bitten by one of these things and have anaphylaxis, but certainly upon repeat exposure, that is where the risk does start to add up in these individuals are just higher and higher risk of potentially having a much more pronounced, a much more severe reaction. And I think the one thing to be aware of is it's not unusual for this to be missed by diagnosticians. And that's not a knock against all you fine folks that are joining us today. It's that this is a rather unusual presentation and I think really veers away from what we all think of when we think an insect bite or a sting. It is quite different from those presentations. And this is a quote from a paper published in the 80s, looking actually of all things at an immunotherapy for some of these triatoma bites for folks with anaphylaxis. But skepticism on the part of family, friends, and physicians is common, at least in the 80s, and I'd argue still nowadays. We've encountered instances where lack of cooperation, misidentification of the bug have prolonged patients' discomfort and placed them in a life-threatening situation. And that is owing to, as Dr. Klotz had mentioned here, some of these individuals, although thankfully too, not relatively common, that these may be bugs that have set up shop in some of these places, and folks may be experiencing a number of bites. And again, if they're having these reactions, that risk just builds of potentially having some of these anaphylactic or life-threatening issues arise. Victims of hymenopteran stings, so ants, bees, however you want to think of our typical critters out there, victims of those are immediate recipients of concern and consolation. Again, they're relatively painful and oftentimes witnessed. But for many victims of triatoma bites, the onus is solely of their own in these cases. And again, it's owing to the fact these are somewhat insidious, that these things can occur and do have just enough distinction that I think an individual looking for it could develop a suspicion. It seems like it might be from a kissing bug bite. Now, as Dr. Klotz had mentioned, there's 10, 11 different species of these triatoma that we talk about, but 5 are specifically linked to having more of these local reactions or these anaphylactic problems. And that's rubida, protracta, gerstacheri, sanguisuga, rubrofasciata. And differences here are really where we're looking at in parts of the country. Rubida tends to be more common here. California has a bit more of an issue with protracta. And those tend to be two of more of the common ones, especially that we're going to deal with here in the Southwest. But make no mistake, some of these others, a bit more obscure to have these reactions, but there are published case reports. The most frequent or recent I saw for rubrofasciata was published around 2015 in an individual that had multiple anaphylactic episodes because they were bitten by these darn things 3 different times and had the exact same response. Now, if we're talking just localized symptoms, what are you expecting? Now, for starters, this may not necessarily be from salivary antigens. It could be from some other debris that's getting in there, irritating the wound. A number of different things may come into play here. But we're looking at itching, tenderness at the site. And again, I think this is taken from one of Dr. Klotz's papers here that he published. Actually, also with Dr. Beatty, who, if you've been following this series for a while, talked a little ways back on different snake bites. Looking at the wound too, it can become edematous, reddish purple in appearance. Now, let's say you do absolutely nothing. Typically, the duration may be anywhere from 1 to 2 weeks for these things to resolve on their own. But let's take it to the next level. What would be something that could be more concerning from these bites? Certainly a prolonged reaction. There are some cases of delayed reactions that can present, but things presenting beyond 2 weeks, I would have a much higher suspicion something is not quite right here. Going back to our case, nausea, vomiting, diarrhea, gastrointestinal issues can be thrown into the mix here, certainly more severe. Now, vaginal bleeding is admittedly an unusual one to think of from triatoma bites, but the reality is this is something that equates more with anaphylactic episodes in general, possibly from uterine contractions that are occurring as a result of significant systemic response, and not necessarily something that's unique to a kissing bug bite in that response. Now, I think the more obvious ones we're looking for, angioedema, hypotension, presumably our poor fellow in our case experienced this when they had their syncopal episode and got up. Stridor, wheezing, it seems like maybe even starting at home, but certainly on the way to the emergency room, this individual had some respiratory compromise and ultimately end up intubated as a result of presumably a kissing bug bite. But again, awoken from sleep. So this is an unusual presentation for these more severe anaphylactic episodes. There's other causes that could potentially present this way, but unusual. I've seen crossover with red meat allergies that can present this way. But at least if we're thinking Southwest, an unusual cause, an individual awoken from sleep presenting with some of these symptoms, I would have some suspicion. Could this be a kissing bug bite? Potentially. It's absolutely worth probing. Now, differential diagnoses, I think, are worth talking about, but now that we've had this presentation, I hope a bit easier to suss out what might be going on. As Dr. Klotz mentioned, I think the physical presentation, just what you see with your eyes, it may be easy to mistake this for other stings or bites from other insects. But as he mentioned, typically we think of those as being painful. And that is something that sets apart, at least early on, these triatoma bites, is typically we're not seeing something like that. Now, as you saw with that picture that we had there, there's a number of different presentations. There's a very colorful picture by an individual that was bitten. It appeared multiple times in Texas, and it even made their newspaper. And it did. It looked to its credit somewhat like shingles. It followed what appeared to be that dermatomal pattern. And that's another way to separate, is this shingles or does it not quite follow those dermatomes that we would typically think? Contact dermatitis, certainly in your questioning, well, what else did you get up to? There have been cases where this may have been misidentified. Somebody rubbed up against a plant that they had a reaction to that, and that could explain this. Now, the last bullet point I think is worth considering for a couple of reasons. Certainly, skin and soft tissue infections can start their presentation similarly. But I think it's also being aware that at the time of presentation, could someone have essentially a localized reaction from a kissing bug bite and have a super infection or a cellulitis on top of it? Absolutely. So another thing I think to keep in mind with how that patient might present other symptoms. Now we just saw this table. Again, this is pulled directly from not only Dr. Klotz, Dr. Beatty, we got Dr. Shirazi on the action with this one. So all of the old favorites from here all teamed up their efforts for this particular paper. And this was pulled from calls into the Poison Center around 2014. And it had 10 different individuals. And whereas Dr. Klotz focused on the conditions of the home, I want to draw attention to the bottom half, and that's looking at, well, what did these individuals actually report? And I think the big takeaway that hopefully will help dislodge that idea of Chagas being of primary concern and more the potential for these reactions. 10 out of 10 of these individuals did report a localized reaction to the bite. 9 of them had local erythema, itching. 3 of them sought medical care. 4 of them had dizziness after the bite, and 2 of them said they had difficulty breathing after this bite. Now, again, for many of these individuals, there could be the element of they may have experienced multiple bites. As we can see here, 90% of these individuals saw bugs in their home within the past month. So there's always that concern. You're seeing someone who's probably or potentially been bitten multiple times, and now there is that concern for a severe reaction potentially happening for them. So let's say we've identified, or we're pretty sure this is a kissing bug bite reaction. As has been mentioned a ton, repeat bites do increase the odds of having that anaphylactic response. If someone has had an anaphylactic response, much like anything else, this individual is pretty definitely going to have another anaphylactic response if bitten by the same triatoma bug again. And Dr. Klotz, weigh in here too if this isn't true, but in terms of cross-reactivity, if let's say an individual was traveling, maybe they went from Bisbee over to San Diego and were bitten by, let's say in that case, a protractor. I'm not seeing any incidences of cross-reactivity. Does that match with what you've seen? Oop, you're muted.
That is true, Larry. There is no cross reaction. Dr. Pinnis in University of Arizona back in the 80s showed that with triatoma recurva, rubida, and recurva.
Awesome. So, biggest thing that you can do here, at least as far as this goes, it's exactly what you think it should be. Treat this as you would an anaphylactic episode. Getting that immediate epinephrine is crucial. Insofar that if you identify an individual that you are pretty sure has had, let's call a concerning reaction to a kissing bug bite, I would prescribe that EpiPen or whatever product you can get your hands on, have that in the individual's hand, and ideally keep it at the bedside. That's likely the place that will make the most sense, depending on how that patient presented for a reoccurrence of having this happen. Now, for the sake of time, I'm going to jump through this real quick. It is of note that immunotherapy has been tried. It certainly doesn't exist present day. It never really did, but it was attempted. So we had talked about the local reactions being potentially from some debris or whatever that may have occurred during the exposure. But certainly the salivary antigens are where this anaphylactic episode is, of course, coming from. And a couple of papers published, one looked at 5 different individuals, another focused on one in particular. They were using the salivary antigens for Triatoma protracta and trying to help prevent anaphylaxis in individuals that had had it. And to their credit, it actually looked like it worked not terribly. In the one paper with 5 people, 4 of them did not seem to have an issue at a later rechallenge. This occurred about half a year after they had started this therapy. Now, the 5th individual, it did have a milder response, a milder case of welts that actually at a much later rechallenge, they didn't have any reaction at all. Now, in the other report where one person was looked at, similar to that 5th patient, had a response, but it did seem to be milder. Now, in conclusion, so again, following up from the same case that Dr. Klotz had mentioned, a tryptase was obtained. I think we all suspected there was probably an anaphylactic component, but that all but confirmed a severe allergic reaction was happening. The wife did find a bug in the patient's bed, and in this case was identified as Triatoma rubida. And the primary treatment it's administered, I don't think is going to blow anyone away. Fluids, diphenhydramine, epinephrine. There's cases too where folks may have gotten a corticosteroid injection, but I would highlight the epinephrine is critical in getting to these patients as quickly as possible. And all is well that ends well. This person recovered very well, was discharged with their own EpiPens, sent back home. So overall, the conclusions here, the allergic reactions, I think are easy to miss because it is an unusual presentation, but it's easy to, I think, push this off and assume it's any ants, bed bugs, what have you. But I think also when we think kissing bugs, we think chagas. We go right for the worst case scenario, which is incredibly rare that that's going to be the case. Knowing what you all know now, I think that asking just the right questions can certainly help pin down this might be related to a kissing bug. The big takeaway that's always stuck with me is when individuals are awoken from sleep and they have these symptoms. It does make me wonder, it might be more a kissing bug in this case, and not something we typically would think for an anaphylactic or a severe allergic response. Again, best treatment, immediate administration of epinephrine, and providing them a prescription in case this happens in the future. It absolutely can be life-threatening, and in the absence of any immunotherapy, which there is really nothing available for that, if this exposure were to happen again, I'd absolutely expect the same, if not a worse response in the future. And that brings a conclusion to this. So let's stop sharing this and make sure we got about 4 minutes. Let's get our questions written up here. All right. Oh, a question for you, Dr. Klotz. So the same individual that had that bite and did the PCR, so their exposure, they had the classic two puncture bite on their lip. But from what you saw, what percentage of these bites do occur in other locations?
Well, in that very same paper that Larry took that table, we looked at the different parts of the body that were targeted by kissing bugs in over 100 people. And they had a choice of just responding, well, most of them, my most recent bites were all in the legs and so forth. That's generally the story that occurs. And on the face was less than 15% of the bites. So this
Wow.
idea of kissing bugs is a little unusual. I mean, the attraction there is the superficial capillaries around the conjunctiva or the mouth parts. And there's not, having two spots where little blood would be unusual, but they often move. If the human or the victim moves, the kissing bugs will back off and start over again in adjacent tissue. Uh, so, yeah, that was a pretty interesting story, I'll have to admit.
Any other questions? We've got a couple of minutes. It's rare that we have time for questions nowadays.
Well, Larry, that was a fantastic presentation. I I just marvel at your degree of sort of a textbook approach to everything.
Well, I think for this, I mean, I'm just as guilty as everyone else. You tend to think Chagas as being the big thing, but the reality is it's a much bigger problem that thankfully in a lot of cases may not be as severe, but something that I think we could keep our eye out for sure.
Yeah.
I always enjoy hearing your guys' presentations on these things. I do want to let everybody know it's August 21st is our next in this series, and it will be on scorpions with Dr. Klotz and Dr. Shirazi. Will be back to entertain us. And of course, there'll be more coming up in this fall when we get our topics, and we'll be sure to be putting them together and making sure everyone knows when to sign up. Wednesdays tend to be our most common day that we have the series on, and we appreciate everybody that joins us, especially our EMS group that has been following along, since you are the folks that usually see these things in the first place before they get to the ER. So we really appreciate you following us and checking in and joining us. Any last comments for today's session, Dr. York or Dr. Klotz?
No, thank you very much, Chris and Melanie, and excellent job.
Great. And again, Dr. York, you're looking really good with your tie today.
I try. I ditched the jerkin for a tie.
Oh, and I will get the information out to everybody that's attended on for the CMEs for this. That'll come in my email shortly, and then you'll be able to go ahead and and request those. All right, so with that, we're right on time. Thank you again for joining us, and we look forward to seeing you all again in August, and have a great rest of the week. And we'll see you later.
Hi.
Have a good one.
Thanks, everyone.